Hi everyone, I'm Linda from Diabetes Tasmania. I'm your host tonight. We still got another 5 minutes to let people come through, but I can already see a few of you joining us. That's great. We're expecting a few people tonight, so we thought we might as well open the webinar a bit early so that you can all come in, get set, check your volumes, see that everything's working over your side, making sure that all those headsets and volumes are right. We will start at 6:30 and we got an hour allocated for the webinar. So we'll have a couple of different presentations and presenters that I'll be sharing the details of in a little bit, but we'll give it another 4 minutes or so. So tonight's webinar is actually the first webinar that Diabetes Tasmania has put together in this shape and form. So we're really excited and can't wait to sort of kick off the first one. The next one is on Wednesday next week, and we'll be sharing more details about that one as well in case you missed it. And we're hoping that perhaps this is the first one, but the first one of many. So we're really excited to have so many of you joining us tonight and joining us live as well, which is always a bit daunting. You never really know how the tech is going to work or not work, but luckily we got our tech support with us tonight as well. So hopefully we don't need to use them. But I think the entire team who you'll be meeting soon are pretty excited. So we've got a few more joining us. I can see the list, and we got another 2 minutes before we're going to start. So if you need some water or a hot drink, maybe you're having your dinner, you got another 2 minutes before the webinar will be kicking off. Just going to do a quick intro again. I can see a few of you have joined. So we are starting the webinar at 6:30. We just thought we should open the session a little bit earlier so that you could come online, settle in, grab your food, your drink, and check your volumes and all the tech so that you're all ready to go when we start. So we've got 1 more minute. And a few more joining us, exciting. So we're about to kick off. So make sure you got everything ready. All right, so I might just get everyone who will be speaking in tonight's webinar to turn their cameras on. Hi, everyone. So we're going to start the webinar now, and I just want to note that this is being recorded, and we will be here tonight. We got up to an hour. So welcome to tonight's webinar, Understanding Diabetes Self-Management Principles. For those of you who joined a little bit early, you know that this is the first out of 2 sessions. But before we begin, I'd like to do a quick acknowledgement of the traditional owners, past, present, and emerging, of the many lands that we are meeting on tonight. And I would also like to extend that to any Aboriginal and Torres Strait Islanders participating in our webinar. So my name is Linda Carson, and I'm the communications lead here at Diabetes Tasmania, and I'll be your host for tonight. So as you can see, we have a couple of speakers with us tonight. We have Myles from Diabetes Tasmania, who will talk to us about diabetes diagnosis and registration on the NDSS. We also have Elisa, another Diabetes Tasmania staff member. She'll be talking about information prescriptions and one-page prevention strategies. Finally, we have Neroli from the Royal Hobart Hospital, who we're really excited to hear from tonight, who will finish off the webinar talking about choosing the right medication for type 2 diabetes. So you can see everyone at the moment on the camera, but when we do start off the presentations, everyone except for the speaker will go off camera. But don't worry, they're still here and they will be here the whole night. So you'll also notice that we do have a Q&A function enabled. So if you do have any questions throughout the presentations, please post them in the Q&A. So we will have a part at the end of each presenter where we will answer the questions, but whoever is not presenting will also answer the Q&As throughout the presentation. So don't wait until the end, just start posting as soon as you have a question. The chat is also disabled, but enabled for us. So we will be posting links in there throughout the presentation that the presenters are talking about. Now, before we begin, I just want to mention that this webinar is funded by the NDSS. So NDSS is a free Australian government initiative for people living with all types of diabetes. And it provides support, services, information, and subsidized products. Now, NDSS is administered by Diabetes Australia, and Diabetes Tasmania is the state agent. So it's really important that we register patients on the NDSS because the Australian government uses statistics obtained through the NDSS to identify the number of people in each state or territory with diabetes. So by registering all your patients, the government has a more accurate idea of the number of people living with diabetes in Tasmania. And now this is important because it's also connected to government funding, and it's allocated based on the percentage in the NDSS, and the same goes for the funding that Tasmania then receives. But I think it's time to hand over to our first speaker. So our first speaker is Myles, and he's going to talk about diabetes diagnosis and a bit more about the NDSS. All right, over to you, Myles.
Thank you very much, Linda, and thank you. Welcome to everyone. Thank you for taking your time to visit with us. So my name is Myles Fletcher. I'm a registered nurse and credentialed diabetes educator. I work as the diabetes lead and service development lead here at Diabetes Tasmania. I'm going to just quickly go through what the process is for registering people on the National Diabetes Services Scheme and how you do that, why you might do that. And one of the requirements to do that accurately is to understand how you would know if someone's diagnosed with diabetes. So I'll quickly touch on that as well. So just to cover who can be registered on the National Diabetes Services Scheme, who can register someone, sorry, a health professional with a current Medicare provider number, so general practitioners, nurse practitioners, endocrinologists and specialists working in diabetes can do it. Credentialed diabetes educators, it's one of the perks of being a credentialed diabetes educator. But as of the 1st of August last year, practice nurses with a current APRA number are now able to register people on the NDSS. It's part of a drive really to support people to get onto the NDSS as soon as they're diagnosed. There is the caveat that if it's within your scope of practice, knowledge and experience to do so, which really we read as, you know, understanding what the diagnosis would mean, because you need to confirm that diagnosis of diabetes. Just to cover who you can register on the NDSS, so who's eligible. We don't register anyone with pre-diabetes, and we do register people with the main types of diabetes, with type 1, type 2, gestational diabetes, and some of the other lesser known or less common types of diabetes. I've given you a few examples there, which would be registered under the heading of other. There's a comprehensive list of what those other diagnoses can be found on the NDSS website, which I'll refer to a bit later. The prerequisite for anyone being registered is that they're a resident of Australia, so they have a Medicare number, and that's something you'll have to provide in the registration form, which you'll see when we go through that. So the most important thing to do is to establish the diagnosis of diabetes. What I've got here is just a copy of the flowchart that's available in the RACGP guidelines on type 2 diabetes. The first thing, you'll notice that this heading is under for asymptomatic patients. It's more common that people with type 2 diabetes, for example, don't necessarily have symptoms of hyperglycemia or high blood sugars. So you might be guided by the OSD risk, or the risk of someone getting diabetes. The OSD risk I'm not going to go through, but it is available online if you search for it. It is an established risk score that can be generated based on a few parameters. And if a score of 12 or more would put someone at high risk of getting diabetes over the next 5 years. So if someone scores that high, then you would possibly then screen them for diabetes annually. If someone's symptomatic, so the common symptoms of hyperglycemia or high blood sugars, thirsty, tired, toilet, think of the T's, toileting. Sometimes if it's excessive, you do see weight loss. People often will put these symptoms down if they're fairly mild to just getting old or working too hard, not getting enough sleep. So it's really hard to distinguish hyperglycemia just on symptoms alone, which is why we try and screen people, measure risk. So confirming hyperglycemia, we've got the HbA1c or hemoglobin A1c blood test, and the reading there of 6.5% or more. Just remember it's a percent, it doesn't mean that their blood sugars are 6.5. So 6.5% or more would confirm a diagnosis. If they're asymptomatic, the guidelines would state that you'd repeat that again, the same test, and if 2 in a row would mean that would confirm a diagnosis. If you were to do a fasting blood glucose, then anything 7.0 or above, a random blood glucose 11.1 or above, and there's some parameters for an OGTT as well. Just to clarify what pre-diabetes would be. So generally we would say anyone sitting between 6.0 and 6.4% on an HbA1c. Just remember this is a retrospective test that's measuring the average glucose over the last 2 to 3 months. Or a fasting plasma glucose 6.1, 6.9, and then a 2-hour random 7.8 to 11.1. So anyone with pre-diabetes, you're not going to register them on the NDSS, but they would certainly then fit under your high risk of diabetes, and you would monitor them, and possibly they could benefit from some education as well. Sorry, there's a bit of a delay with the slides. I'm just waiting for that to kick over. Just as while I'm waiting, with the HbA1c, anything targeting care, anything around 7.0% for most healthy adults. So if you're seeing an HbA1c over 8, 9, or 10%, then that would very much confirm diabetes, and they probably would be symptomatic. One of the next steps would be to distinguish what type of diabetes the person has. Now, as we know, the most common type of diabetes is type 2 diabetes, which is defined as a relative insulin secretion decline on a background of insulin resistance. So you've got not enough insulin being produced, but and often that's driven by the body not being sensitive to the effects of insulin, so it's not working as well. Type 1 diabetes is distinguished as an autoimmune disease. It's very much a specific diagnosis of specific pathophysiology that needs to be confirmed by the presence of autoantibodies in the setting of hypoglycemia, and often with ketosis, because the autoimmune process destroys the beta cells in the pancreas, so there's very little insulin production. By the time they become symptomatic, there's usually weight loss and ketones, and those those other symptoms of acute hypoglycemia. The autoantibodies are listed there. That's a special test that have to be ordered to confirm type 1. So just be mindful, I guess, note that diagnosis is not always clear cut, and we see this quite a lot, especially in adults. I mean, if it's a child, it's most likely going to be type 1 diabetes. In adults, we still see 50%, around about 50% of new diagnoses of type 1 diabetes in adults or people over 25. So it's not uncommon for people to be misdiagnosed with type 2 diabetes as adults, and they've actually got type 1. So just be mindful of that. When you see very high hypoglycemia, it might be worth investigating. This is the form, the registration form that which is the NDSS registration form, sorry. This is available on the NDSS website. It is available in some practice software as well. It has been reduced recently, a few years ago now, to 2 pages, so it's not as onerous as it used to be. I'm just going to quickly walk through what you'll have to do. The boxes I've highlighted here, so questions 1 and 3, and the rest of those questions, they really are just looking for the personal details of the person you are registering. Again, just to flag, you need their Medicare number there. If they're on a concession card, like a healthcare card or a pensioner card, then don't forget the expiry date down the bottom under question 12. And just making sure you ask if they identify as Aboriginal or Torres Strait Islander origin, and where and when they were first diagnosed. The grey section here I've very rarely used. It is there as there are a couple of countries in the world that have an agreement with Australia, so they may not have Medicare numbers, but they might be eligible to be registered if they come from those countries, and you'd fill that section in if that was the case. And as I said, it's very, very uncommon. Finally, if there's a competent adult who you are registering, this is where they would sign. During COVID or since COVID and lockdowns, we've been able to skip this part because of telehealth. If you can get the person to sign, that's great. At present, it's not a requirement. On the second page, you'll see the follow-up. So if you were registering a child or someone who wasn't competent adult, their carer or guardian would sign here and fill out their details. The next sections I've highlighted are questions that just distinguish the person's diabetes, who's confirming what type of diabetes they've got. 37 and 38 and 39, the questions really just around what their treatments are. Specifically, if they're on an injectable and need access to free needles, that's what that section is for. If they're just managing with orals, then you'll just tick those boxes in number 37. The section in grey is only for people with gestational diabetes. So if you happen to be registering someone with GDM, then the baby's expected date of birth and the name of the GP goes in there, and that's for some follow-up postpartum. And finally, you're going to put your details or the certified details in here. So as a CDE, I'd put my CDE number in there. As a practice nurse, you'd put your APRA number in that second line. And then you're going to tick question 41. Unless you're a GP or nurse practitioner, you will just have cited the documentation relating to the diagnosis. So that you would have seen the HbA1c or the OGTT or fasting plasma glucose result that confirms the diagnosis. There are two other forms that are worth knowing about. Again, they're available on the NDSS. The one is the blood glucose monitoring strip 6-month access form. So just to remind people that the NDSS doesn't automatically subsidize glucose testing strips for everyone with diabetes. If you are newly diagnosed, you get 6 months access. If you're just on diet control or just being treated with metformin, for example, after that, you would need to apply for further 6-month access. Now, there's good reason for people who are not on insulin or taking hypo risk medications like diamicron. There's good reason for them to monitor, then that's fine if they want to monitor. It just needs to be completed every 6 months. The syringe or pen needle access form, that's simply if you have someone with type 2 diabetes who then has to progress onto using insulin, that gives that updates their registration so they can access free needles if should they need to. Again, those can be signed off by you guys or by practice nurses, I should say, and can be found on the website if you need them. The last thing I'd like to mention is just that Linda's mentioned the benefits of registering with the NDSS. It is a register, so there's benefits there. It is also a really great support for and provider of information and reliable resources. One of the things that will happen when they are registered, they will get a pack in the mail, which includes their NDSS card, the information for people with type 1 diabetes booklet and type 2 diabetes booklet. Just flagging that so you guys are aware, you can find these online as well, but knowing that your patients are receiving these booklets and ask them to bring them in for their appointments because they're very useful. They pack a lot of information in them. They can be used for teaching purposes as well and to refer people if they've got questions around their diabetes and self-management. So a very useful information pack that you should know about. And that's it for me. So just to recap, really important, you've registered someone with diabetes on the NDSS. You are able to do that as a practice nurse. All you need to do is confirm that diagnosis. And hopefully you can always refer to ROCGP guidelines, but hopefully that's clarified for you, HbA1c above 6.5% or a fasting glucose above 7% with or without symptoms. So thank you very much.
Thank you, Myles. So we had one question come through, and one of the participants was asking, referring to one of the slides that you had, whether all those autoimmune tests are necessary to rule out type 1 diabetes.
So they're usually ordered as a panel. You do, to confirm type 1, you would only order that if you suspected type 1. Because they are expensive, it's an expensive test, so you would test for the auto antibodies. I think they would normally test for 3 or 4 of them. And if there was a positive for any of those, that would confirm type 1. In the setting of hyperglycemia, type 1 is less inherited or genetically inherited, but if there's a family history of other autoimmune diseases like thyroid, celiac disease, that would raise your suspicion. There is another test you would check for how much insulin the person is producing, and if that is low, so it's not testing for insulin, testing for C-peptide, which is a protein that cleaves off insulin when it's produced. So there's a way of testing for how much insulin is being produced, because there is an argument for idiopathic type 1 diabetes, meaning they present in all clinical presentation looks like type 1, but we can't find an autoimmune cause. So it is tricky, and I think if you have any doubt in primary care, in general practice, I would refer anyone you suspected of having an autoimmune cause of diabetes onto a tertiary centre, and the hospital diabetes team to follow up.
Thanks, Myles. So that was the main question. I'm going to introduce Elisa next. And there were a few people who joined us there whilst you were talking, Myles. So for those of you who joined us then, we do have a Q&A after each presentation. So post your questions throughout the presentation and we'll cover those off at the end. And we'll also answer them throughout. And also those links that we are sharing with you in the chat, we will be sharing the slides as well. So don't feel like you need to save and bookmark everything. So our next presenter is Elisa, and Elisa is going to talk to us about information prescriptions. So I'm going to hand over to you.
Thanks, Linda. Yeah, hi everybody. I'm Elisa. I'm one of the diabetes educators that work out of the Devonport office of the Northwest team, for the Northwest team. I'm really pleased to actually introduce to you information prescriptions. I was actually working on the project over the last couple of years. So we've actually just in June had them launched as a part of the NDSS suite of resources that are available. Each of the information prescriptions are personalised single A4 sheets of resource. That easy to read explanations, and they give clear diagrams of what's happening, and you're able to set individual goals. They're designed to give people living with diabetes the information that they need to understand, engage and improve on their health targets. We know that diabetes is really complex and that people with diabetes have a lot that they need to understand in order to be able to work on those health targets. So information prescriptions are designed to be able to break down that information into smaller pieces of information that they can understand and help them make lifestyle choices that will help to improve those health targets that we're always talking about. Originally, they were developed in UK by Diabetes UK, and what we've done is actually adapt them to relate to Australian language and our targets as well. So we have 10 different information prescriptions available, and there are 3 core prescriptions. There's the blood pressure, HbA1c and cholesterol. So unfortunately, we know that less than 50% of people living with diabetes are actually able to achieve targets. And so that leads to complications like kidney disease, blindness, strokes and heart attacks. So helping anything that we can do to help them achieve those targets is going to be really helpful. The other types of information prescriptions we have are around foot health, planning pregnancy and contraception, emotional well-being and diabetes knowledge. So here you can actually see what one of the prescriptions looks like. At the top of the page, there's an opportunity where you can fill in information like their blood pressure, their last results in their kidney function, their last HbA1c results, and you could also put in what their target might be. And it gives you the opportunity to discuss what the condition is, why it's important to think about this as part of their care, and then breaks down into activities that they could consider to make changes to help achieve that target. And then what I really like about this is and it's really interactive. So then after you've had the discussion, they can choose what they're going to take on, what they might do to achieve the target, and then you can help complete the goals and a review date so that they can come back in and see how they manage next appointment. They're available on NDSS under information prescriptions, but the thing that I really like about this is that we've been able to have them put into medical software. There is a toolbar called Health Share that some practices will have, and you can find them under their title in HealthShare. But we've actually had them put into supplied templates. So with the supplied template, they're actually all available nationally within the best practice software and medical director. And they're also available in Inca Health. So if you're using Inca Health to do care planning, you'll find them in the care planning tool. If you're using patient-centered or clinical care planning, they're under tasks or goals. So I think that's really important because it's helping to engage in their care planning specifically as well. So I thought it might just be handy. A lot of people use best practice. So just to show, it's in the supplied, you go into templates. So you've got the patient in the room, and these are only short, brief interventions. So it's not it's not replacing fact sheets, but you would click on the resource that you want to talk to the person about their diabetes, open it up in the file, and then another window will come up where you can actually put in the information like their blood pressure. So then it fills in the document into their history, so into correspondence. So you've got a record of that conversation and that what you've come to plan with the person, but also then you can print it off and give it to the person to take home as a reference as well. So I think that, with all those, having that option, it's engaging with the person in a regular routine appointment that you might have. If you're the GP, time's fairly short, but you've got enough time to grab that resource, go through a piece of information with them and guide your discussion. It's good because it's evidence-based information. It will prompt you to consider whether you want to refer the person on to any other allied health professional. It prompts you to think about medication. It prompts you to think about what the target might be and to have that real honest discussion with the patient. And I like that it promotes consistency in messaging around providing that information to people living with diabetes as well. It's great that it's quick and easy, like I said, and it also promotes that self-care and care planning as well. So hopefully you'll find them really useful. When you're at work next, log in and have a look in your software, or go to the Diabetes Australia website and you'll see where they are and just get comfortable using them. And if you've got any feedback at all about the resources, I'd love to hear from you. Thank you.
Thanks so much, Elisa. And when Elisa says that she's open to the feedback, she really is, because Elisa is the key person behind translating this from a UK context into an Australian context. So it's really amazing, actually, to see this come to life. And now we can't wait to see it being used as well. So in terms of questions, we don't actually have anything coming through from the audience, so it seems to be quite straightforward. So what I might do is I might bring in Neroli for the last presentation, and then as you sort of sit and think about what Elisa has been telling you for the last 10 minutes or so, and you got any questions, just post them in the Q&A, and Elisa will be with us and she'll answer them throughout Neroli's presentation as well. So with that being said, our next speaker is Neroli from the Royal Hobart Hospital. Royal Hobart Hospital. I just had a second thinking, did I say that right? But yeah, I did. And Neroli will talk to us about choosing the right medication for type 2 diabetes. So Neroli, I'm going to hand over to you.
Thank you. Thank you all for joining us this evening. As said, I'm Neroli, the Diabetes Nurse Practitioner at the Royal Hobart Hospital. And I'm going to be exploring with you tonight the medication management in type 2 diabetes. Beyond that of just glucose control, but also considering that of the management of cardiovascular disease, cardiovascular risk factors and cardiovascular risk protection. So I want to start by sort of saying that we're going to touch a little bit on the progressive nature of diabetes and just review a little bit about the pathophysiology of diabetes. Myles has very nicely set that up for me this evening. We're not going to go into a great deal of detail, but I just want to sort of cover a couple of basic things. We're going to look at the oral agents and the injectable medications that we use to manage type 2 diabetes and have a look in a little bit more detail around the management algorithm. And then also within that management algorithm, think about the cardiovascular protection and the algorithms that sort of align with our national guidelines and just ongoing considerations to sort of take home and think about with your practice. So firstly, in terms of our revision of the different types of diabetes, I just want to remind everybody about our different types of diabetes, being that we have type 1 diabetes and type 2 diabetes. So, and there are other different subsets and obviously gestational diabetes, but for the purposes of our management algorithm, we'll sort of stick to the type 1 and the type 2. So type 1 diabetes is an autoimmune disease and it's characterised by beta cell destruction and a lifelong reliance on insulin. So people do initially at diagnosis have what we call a honeymoon period where the person with diabetes is making their own insulin still, be it a small amount, but we're also giving them insulin as well. And during this time, insulin amounts that people are having usually fall. Some people are able to reduce their insulin intake or reduce injections or even stop injections during this time. But eventually their own insulin production will die off in the same way the other insulin production has died off, and that they'll need to then obviously be reliant on the insulin. So there is a lot of focus on trying to preserve beta cells during this time. And there is some research that has gone into using oral agents to be able to, that we predominantly would use in type 2 diabetes to sort of get more preservation out of our beta cells. And one of those medications are the DDP4 inhibitors. There has also been quite successful trials that have been published using SGLT2 agents and metformin, but more in the context of an adjunct to insulin and usually in the context of insulin resistance in order to try and reduce the amount of insulin that people are having to give themselves. Then we have our type 2 diabetes, which is characterised more around beta cell dysfunction and decline rather than a complete sort of killing off of our beta cells. And we're able to use oral agents and lifestyle management therapies to be able to manage our diabetes a lot more. But then also we do add in insulin, and we also at every point will still be looking at our lifestyle management. So I'd like to just explore this in a little bit more detail. So we have our progressive nature of type 2 diabetes, and I think this is something that I talk a lot about with my patients, and I talk a lot about with the nurses that I work with, and having patients understand that diabetes is a progressive disease, type 2 diabetes, and that and it's been going on in the background for some time, often more than they realise prior to that diagnosis. We know that in the lead up to that 4 to 7 years and that impaired glucose tolerance before the frank diabetes is actually diagnosed, that's usually at that point people are able to achieve a reversal of their diabetes or almost put it into remission. We can never cure our diabetes once we've been diagnosed of it, but we're able to definitely sort of reduce the glucose and delay that progression at certain time points. But obviously, once frank diabetes has sort of been clicked over into, and we're sort of starting to get much further down that decline, it makes the remission very difficult, because in order to be able to have a remission in our diabetes, we still need to be able to be producing some kind of insulin within our pancreas. So the management options that we use in diabetes will tend to target different parts of the body in which we use for glucose regulation. So the areas of the body that our tablets or our medications for diabetes will target are organs such as the liver, our fat tissue, the brain, muscles, our gut, the pancreas, and more recently, we have drugs that act on the kidneys. And these are all target sites for our oral agents and our injectable medications. So if we have a look in a little bit more detail around type 2 diabetes and the medication management, we'll start off by looking at the oral agents that we will prescribe in the context of type 2 diabetes. So the first being good old common metformin. It's our big biguanide, and that has a target organ site of the gut and the liver. So, you know, there is obviously many schools of thought around the use of metformin, and that a lot of people feel as though it should be one of those drugs included in our water. Maybe there's sort of effort around that, but it reduces our hepatic glucose output, and it tends to lower our fasting glucose. Some people do find it difficult to tolerate, and it is contraindicated in an eGFR of below 30. Secondly, we have our sulfonylureas with the target site of the pancreas. These are more commonly known as the diamicron or glycoside, and that will stimulate insulin release quite directly from the pancreas. So we therefore have a precaution with that medication around hypoglycemia or our low blood sugars. The DDP4 inhibitors will act on the gut, the liver, and the pancreas. And these are drugs such as the linagliptin or sitagliptin or Januvia. And these drugs will stimulate beta cell release by decreasing our GLP-1 hormone. Then we move into some of the two of the older drugs that we don't really tend to prescribe as much anymore, the TZDs or the thiazolidine diodes. And that is an action site at the fat or our adipose tissue. And these drugs are insulin sensitizers. And unfortunately, quite a few years ago now, the FDA actually pulled the use of these drugs, and we have very heavy prescribing limitations around them within Australia. They are available to be prescribed, but in fact, it was found that these drugs significantly increase the risk of heart failure, the very thing we're trying to avoid in diabetes. And it also increases the risk of fractures and bladder cancer. So it must be a very specific patient that we would ever prescribe these drugs in. We also have good old Archibos, again, not a drug commonly prescribed in modern times, a drug that targets the gut and will lower post-meal blood glucose levels. But our new kids on the block, the SGLT2 inhibitors, the dapagliflozin or the empagliflozins, also known as Jardiance. These drugs have a direct effect on the kidneys, and they prevent kidneys from reabsorbing glucose, which then gets just urinated out in normal process. But again, I just add in here that there is precaution around prescribing these drugs in patients with a reduced eGFR, so anything under 45 we wouldn't recommend. And also that there is a tendency for patients to actually develop a euglycemic ketoacidosis, meaning that ketones can be present in the blood even when blood glucose levels are at a normal range. So that will commonly occur when people are fasting for procedures or have been unwell with gastro and they're not eating but still having that medication. So it is a very common thing that can happen. And it's definitely something that we provide a lot of education about to our patients when we do prescribe these SGLT2 medications. Lastly, we have our injectable medications. Now, I'm not going to discuss insulin in this at all, but insulin is very much included within this class. But I'd like to focus a little bit more on the GLP-1 medications, or the glucagon-like peptide-1 receptor antagonists. So these drugs have been around for a little while. Most common, the first one and the most common one being Byetta, which is a twice-a-day GLP-1 injection. This is different to insulin. The GLP-1s stimulate beta cell insulin release and slow gastric emptying. There's multiple target sites of the pancreas, the liver, the gut, and the brain. But we have moved on from these twice-a-day injections and now most commonly prescribed the once-weekly injections, which is the form of Ozempic and Trulicity. We do have prescribing limitations around the use of these medicines, unfortunately. It would be great to be able to use these in first line or in combination with some of the other drugs, because we know they work so well with some of our other classes of medications. But unfortunately, the PBS just don't recognise it. They are TGA approved to be used in these instances, but unfortunately, our patients do not get it reimbursed. There is also precaution in prescribing these medications as well. I would not ever prescribe it in anybody that has had pancreatitis or a history of pancreatitis. And just to be mindful of the kidney function, in an EGFR under 30, we would usually use Trulicity down to an EGFR of 15. So none of it's only the Trulicity GLP-1 that is indicated in a lower EGFR. So we have many clinical guidelines available to us nationally, I guess, and internationally. But the go-to guidelines in Australia that we generally direct people to within the specialty is that of the Australian Diabetes Society guidelines. These guidelines have their own website, which I'd encourage you to have a look at, the t2d.diabetessociety.com.au. It has more detailed information around the algorithm and PDF print-offs. And on the back of this management algorithm is also detailed information around each medication and contraindications and precautions, as well as commonly prescribed drug names. I would also like to point out the living evidence for Consortium Diabetes, which is another ADS guideline or set of guidelines. And we're going to look into these in a little bit more detail because they actually have more specific information around cardiovascular risk management and type 2 diabetes. So if we look at the algorithm in just a little bit more detail, you can see that we have first line, second line, or third line medications, or our monotherapy, dual therapy, and triple therapy. So metformin is usually our go-to first line medication that's prescribed, but not all people can actually tolerate metformin, or they find it very hard to get through this peak. We do find that people will get gastro side effects often with metformin. It is better off to be able to prescribe a smaller dose, which is titrated up much more slowly. The extended release versions of these medications are much better tolerated than just the general non-XR medications. But if that is not possible, the other two options at this level would be a sulfonylurea, which we would have to have precaution around that risk of hypoglycemia. But also notice that insulin comes in at this point as well. And insulin is recommended both for monotherapy, dual therapy, and triple therapy. It's often a drug that's used more as a last line, or it's used as a bit of a threat, or it's often sort of seen as the end of the road. But in fact, if we're starting to sort of have our conversations with patients and sort of use it further up in our algorithm, patients can achieve very good control with their diabetes, can kind of prolong that decline in or I guess delay that sudden decline in beta cell dysfunction. But there is no reason why utilizing insulin much further up. I think it's definitely a conversation that needs to be had with our patients if they are willing to do that. I guess the other thing to note is that we would be wanting to monitor our medications at 3 monthly intervals and to have a HbA1c done at a minimum of every 3 months. Patients can get Medicared every 3 months for an HbA1c, so for a year. Anything more than that, they will probably get charged. And to be fair, we probably wouldn't need to be doing it any less, but there's also no reason why you can't be doing it at 3 monthly intervals. And then if the HbA1c is not at target, then the expectation would be that we're able to maximise the drug that the patient is on to a maximum amount, or to add in an additional agent and then go through the motions of checking that in 3 months' time and then optimising that medication every 3 months until our target is in fact met. So if we're thinking a little bit more closely around cardiovascular protection, in terms of cardiovascular protection and diabetes management, remembering that we are taking into consideration the prevention or delay of micro and macrovascular complications in diabetes, macrovascular complications being that of large vessel disease and microvascular being that of small vessel disease, so more commonly in our eyes and our kidneys and our feet. We are wanting to ensure that we are offering our patients full protection against atherosclerosis, cardiovascular disease, and heart failure, the two most common things that we're going to see our patients be susceptible to. And so in addition to this, I also would like just to remind and review with you the management and ongoing review of our modifiable risk factors and how important it is to remember that diabetes doesn't just come that of glucose, and that really it's a bit of a trifecta. Managing dyslipidemia, hypertension and glucose levels is exceptionally important in the ongoing and overall management of diabetes. Reviewing on a regular basis general cardiovascular risk, smoking, weight, kidney disease, microalbuminuria. And if a patient does have a history of premature cardiovascular, a history within their family of premature cardiovascular related death, it does also accelerate their risk. And, reviewing these modifiable risk factors is important. In terms of the drugs that we have available to us that have known cardiovascular benefit or offer cardiovascular protection, there is significant evidence to suggest that we have metformin, the SGLT2s, GLP-1s, the DDP4s do have evidence. And funnily enough, we also have the TZDs ticked in this table as well. But remembering that there is a contraindication around heart failure in this class of medication. And in fact, our living evidence guidelines do recommend to avoid this medication in terms of cardiovascular risk, because we do have other options available to us. So the living evidence guidelines for diabetes do suggest that we use the SGLT2 as our first line add-on to therapy in terms of all patients who have an increased risk of cardiovascular disease and multiple risk factors or kidney disease. Then if the SGLT2 is not able to be tolerated or is contraindicated or the EGFR is too low, then our second option would be to add in a GLP-1 instead as an adjunct to therapy in terms of cardiovascular risk protection. But again, if this medication is also contraindicated, not tolerated or not suitable, or is not something that a patient is also able to do, because it is an injection which can be very difficult for some people, the DDP4 would be the third, our third option in that algorithm. So lastly now, just thinking about some considerations to take home and sort of think back in your practice and the patients that you might see. And these, I guess, are things that I've learned over years of sort of working closely with general practice and in my clinic. And, I'd really love to see that ongoing monitoring of HbA1c done at regular intervals. Again, likewise with lipids and blood pressure, there's no reason why those things can't be sort of revised or looked at in a six weekly interval if really aren't at target. And HbA1c, our expectation is that that is being monitored on a 3-monthly basis and medications are optimised accordingly. I think remembering about the benefits of cardiovascular protection in adjunction to weight loss for all of our patients in achieving target and maintaining that target, and reviewing modifiable risk factors and working with our patients and referring them to local services. So sort of looking beyond that of just glucose. We know that diabetes is more than just glucose control. I also feel it's important and quite topical at the moment, given recent television programs, that we do have frank discussions with our diabetes about how likely a type 2 diabetes remission is, and having the distinction between a remission and a cure. Diabetes cannot be cured once it is diagnosed. But definitely, you know, weight loss, eating well, exercising is a really great way of, you know, fastening up that remission. But for how long that remission stays, or we don't know. And then once that remission ends, often people will escalate very quickly through the oral agent algorithm and will end up on an injectable or insulin because it is also, you know, they're reaching beta cell failure. Also, a prescribing note that a GLP-1 medication and the DDP-4 are in fact the same drug. The DDP-4 is a lesser concentration. So if somebody does start a GLP-1, it is important to remember to actually stop the DDP-4. Also remember the kidney function and the eGFR values. I have included that on the previous slide, and just it's usually a benchmark of around 30 that we sort of start getting a bit worried about. 45 for the SGLT2s, but remembering that Trulicity, the GLP-1, can be prescribed in an eGFR as low as 15. And unfortunately, remembering these ongoing PBS prescribing limitations, unfortunately, their PBS do not allow us to prescribe SGLT2s and GLP-1 combinations in addition to insulin. Often patients are then left paying for a private script and not really understanding that there's going to be a cost to them. So I think just sort of understanding that algorithm, realising which medications we need to put on private scripts and how that might work. There are fancy ways of getting around that, or consulting with an endocrinologist or diabetes centre around that. Well, hopefully this has been able to sort of demystify some little bits of things to do with diabetes and cardiovascular risk protection. But I'll hand back to Linda.
Thanks, Neroli. That was really insightful. And I was watching the names of all those different types of medications and just thinking about how many words you need to add to your dictionary to avoid the underlined redness. So I was just thinking about what you were saying around diabetes being more than glucose. And that's one of the things that I think really stood out when I started joining, when I joined Diabetes Tas. We just recently introduced a social worker for people who seek help with us, because often the range of challenges that they are facing are of many various kinds, that even just talking to them about diabetes and how to manage that is something that is not the biggest priority on their list. So definitely being able to support in many different ways is so important. So we had a question actually come in from someone who couldn't join the live webinar, but was hoping to get some help from you. And it's a question that actually a lot of our health professionals get, and I thought I'll just bring it in here. So the question was, I have a patient who is reluctant to start insulin, so afraid of needles, and they're wondering what they should do in those instances.
Yeah, so this is it's a very common thing, and having to start insulin is very confronting for a lot of patients. And I think also, like I had said earlier, where we're sort of using insulin in that algorithm is also quite impactful in this situation, because if it's being used as a threat or a last line, I think that we sort of have to get a bit better with where we fit it into the algorithm. But, you know, needle phobia can be very real for many people and can often prevent people, you know, lowering blood glucose levels and getting better control of their diabetes. So I think, you know, utilising counsellors or psychologists is really important in that scenario. Other things such as the GLP-1 medications, which is only a once weekly injection, is often good in this context. The Trulicity injection is great because it actually hides the needle. It's not, nobody has to screw on a needle or dial up a dose. It's a very user-friendly pen, and it's all hidden. So I've also had a lot of success using that particular device as well.
Yeah, great options there. All right, well, I might leave it at that, and we'll start wrapping up the webinar from tonight. So thanks so much, Neroli. Thank you, Elisa. Thank you, Myles. Fantastic presentations. Now, before you do log off, we do have 2 more slides, so don't leave just yet. The first one is a link to our survey. Please do fill that out. For those of you who joined us at the start, this is the first time we are running a webinar in this kind of shape and form, and we'd love to hear all the good, the bad, the ugly types of feedback from you. So please fill that out. We will also be sending the slides and the recording to everyone, including yourselves and those who couldn't join us live. Next week, we also have the second session of this webinar. So the speakers will be familiar to you. We have Elisa and Myles covering off the topics: diabetes self-management, principles and resources, insulin, and flash glucose monitoring. So these topics feeds really well into what we've been discussing tonight. So please do register yourself. And just like this one, if you can't join us live, you can still register and receive the recording afterwards. And if you have questions that you'd like to ask but can't join live, send them through and we'll cover those off. Finally, if, you know, after tonight, you might be having some new questions or thoughts that you'd like to touch base with us about, could be related to the presentations, Diabetes Tasmania or NDSS, please feel free to contact us, including if you would like to get in touch with any of the speakers. You can see our contact details there on the screen, but you can also just Google Diabetes Tas and get hold of us that way. So that is all from us tonight. Thank you so much for joining us, and thank you for taking the time out of your busy schedule and choosing to spend the evening with us. We really appreciate it, and I hope we'll see you next week, Wednesday, same time. Thank you, everyone.